Hello, everyone. Welcome to NCQA's Fireside Chat discussion. I'm Eric Musser, Vice President of Federal Affairs at NCQA. Thank you for joining this ongoing series. We're so happy to have so many of our quality colleagues join us today. If we move on to the next slide, please, I'd like to go over a couple of logistics just before getting started. We will have time towards the end of today's discussion for audience questions, so please enter your questions into the Q&A function in Zoom, and we'll get to as many of them as we can. We will also be sending a recording of this event and the slides and supporting materials to everyone who's registered today, so thank you for being here. And we invite you to join in on the conversation with us. Please use the hashtag NCQA Fireside on social media and LinkedIn. And please be sure to tag your posts at NCQA. I'm really delighted to have with us today to lead this Fireside Chat, one of NCQA's leaders, Ed Yurcisin. Ed leads our technology strategy and execution. He's our CTO, Chief Technology Officer, and is responsible for providing organization-wide leadership and direction across products and services, enterprise operations, IT infrastructure, and security. Ed is a proven technology leader with significant experience implementing technology and data solutions for healthcare payer and provider customers. Ed joined NCQA in 2022 after serving in C-suite positions across leading healthcare and technology organizations, such as time as the Chief Technical Officer at Embedded Healthcare, the Chief Product Officer at Onyx Technologies, the Chief Data Officer at Care Journey, and the Chief Information Officer at Para Health. Ed also serves initiatives to improve diversity, including developing a technical recruiting pipeline in Latin America. Ed holds a BA in economics with a focus on econometrics and quantitative economics from Duke University. And I'm going to pass it to Ed.
Great, thank you. And I'm joined today with Micky Tripathi. Micky is the Assistant Secretary for Technology Policy, National Coordinator for Health Information Technology, and the Acting Chief Artificial Intelligence Officer at the U.S. Department of Health and Human Services. He leads the formulation of the HHS technology and data strategy and coordinates technology policies, standards, programs, and investments. Dr. Tripathi has over 20 years of experience across the health IT landscape. Prior to joining the federal government, he served as Chief Alliance Officer for Arcadia, a healthcare data and software company focused on population health management, value-based care, the project manager of the Argonaut Project, an industry collaboration to accelerate the adoption of FHIR, and a board member of HL7, the Sequoia Project, the Commonwealth Health Alliance, and the Caron Alliance. Dr. Tripathi served as President and Chief Executive Officer of the Massachusetts eHealth Collaborative, a nonprofit health IT advisory clinical data analytics company. He was also the founding president and CEO of the Indiana Health Information Exchange, a statewide HIE partnered with Regent Street Institute, an executive advisor to the investment firm LRV Health, and a fellow at the Berkman Klein Center for Internet and Society at Harvard University. He holds a PhD in political science from the Massachusetts Institute of Technology, a master's of public policy from Harvard University, and an AB in political science from Vassar College. Prior to receiving his PhD, he was a presidential management fellow and a senior operations research analyst in the Office of the Secretary of Defense in Washington, D.C., for which he received the Secretary of Defense Meritorious Civilian Service Medal. So please welcome me in joining in having Micky join us today.
Great. Thanks, Ed. Really delighted to be here. One thing I should mention that I just learned was that you studied econometrics. We have to talk about that sometime. I spent a fair amount of time both learning and teaching econometrics. So
Ooh, that could be dangerous.
that'll be
So,
fun.
this is now the 20th anniversary of ONC. Can you start by reflecting on the U.S. healthcare system's IT journey and where we've come, how far we've come?
Sure. Yeah, and it'll build up to the, oh, here it's on this side.
Yeah.
To the renaming of ONC to the Assistant Secretary for Technology Policy. But let me go all the way back to the beginning. ONC was founded in 2004 by then executive order, by an executive order by then President Bush, and then instantiated in statute in 2009. And as many people may recall, for those who are old enough, back in 2004, we didn't really have a good idea of how we were going to get health IT, sort of adopted at scale across the country. Their electronic health records were, just appearing on the scene, mostly on the hospital side, very, very little on the ambulatory side. There was growing and compelling evidence that that health information technology could be a factor in helping us to improve issues like the large number of medical errors that are happening in the healthcare delivery system, as noted by the Institute of Medicine, to err as human, and a number of other studies that that started to come out at the time. But it was unclear exactly how we were going to move forward. But I think that with the compelling need, there was a lot of appetite to say we need to be able to dedicate an office at the federal government level to figure out how we're going to do that. So it was founded in 2004. Then Dr. David Brailer was the first national coordinator for health IT, and he did tremendous work helping to lay out sort of the vision for an interoperable health IT ecosystem that I think if you kind of look back, given that we had no idea how we were going to get EHR adoption, it's kind of at a principle level has kind of stood the test of time a little bit in terms of wanting to be able to have access to information, wanting to be able to have network of networks type of capabilities, and a sort of a federated model. I shouldn't say a federal model, a federated model based on non-proprietary consensus-based interoperability and data standards. So you kind of fast forward 2009. High-Tech Act pass, ONC is instantiated in statute, and working with our partners at CMS plays a critical role in the meaningful use program that ended up being about $40 billion in incentives, public incentive dollars provided to provider organizations. I think, as probably almost everyone knows, estimates that I've seen from the private side are that the private sector investment in that was probably 5 times that amount. So an enormous amount of public and private effort. And obviously that doesn't even include the sweat equity, of all the organizations that were implementing those systems. But a tremendous, nationwide effort in many ways for us to be able to turn the most complex sector of the most complex economy that the world has probably ever seen, from a paper-based cottage type industry to one that is in many ways got a very solid digital foundation to enable us to start to build the kinds of digital 21st century digital health innovation and solutions that that all of us want to be able to use. So ONC played a critical role in that time, I think, with the certification program of electronic health records that supported the CMS investments that that were provided to providers. That ended up to the situation where we are today, where 97% of hospitals and about 86% of physician offices across the country are using not just any electronic health record, but certified electronic health record systems. And certainly wouldn't say that those systems are perfect or that that's perfect, but I think that if we just step back and think about the monumental achievement of taking a really huge and complicated and very fragmented healthcare delivery system in the relatively short period of 10 years, from one that was mostly, the vast majority of it, paper-based, to one that a substantial part of it, hospitals and physician offices, being mostly electronic, and positioning us so that we can really think of ourselves as kind of digital natives in many, many ways and start to redraw the way we think about workflows and the way we think about, healthcare delivery, I think is, just sort of a monumental change in a relatively short period of time that we shouldn't lose sight of when we think about, how difficult it still is and how much work we still have to accomplish.
So your group now has a new name, ASTP. Tell us a little bit about the new name for ONC and where it's headed and what we should look forward to.
Sure. So there are lots of things that really excite me about this job. Even after 3.5 years, I'm more and more excited every day. And one of them is related to where I left the previous story off, which is that having laid that digital foundation and going through all of the hard work of implementing electronic health records, which is not pretty. I mean, it's never pretty doing that kind of work. The grand vision turns into Gantt charts and issues and and really hard work and workflow adjustments and disruptions and revenue cycle and all of that. But if we take sort of the Gartner curve analogy for a second, coming out of the trough of disillusionment, I think we're now sort of rapidly rising on the the plateau of productivity, and that's why I think this is just an amazing time for all of us to be engaged in health IT and thinking about all the great things that we're going to be able to do going forward. And that's even before sort of the enablement of large language models and the the wide availability of incredibly powerful AI-based technologies. So all of that is sort of a part of the work that ONC was already doing. And as we were starting to to sort of really think about, all right, what do we want our healthcare delivery system to be? And what does the industry, what do patients, what do providers, what do payers want this health industry to be? And then how can we most effectively partner with industry to be able to accomplish that? So we had already been doing a whole bunch of, a lot of work on things like TEFCA and Fire APIs and, and all of that. Certainly happy to dive into those details. But a big part of what we were doing also was working more intensively with our federal agency partners in recognition that, that all the hard work we had done to lay that digital foundation was in some ways creating a problem that we wanted to have, which is each of our HSS agency partners were doing more and more with those sort of now in place electronic health record systems and trying to do more and more to be able to achieve mission objectives, on behalf of the American people. And that was, it was a problem we wanted to have, and it's a fantastic outgrowth of everything that we had invested in. But one of the challenges we were seeing in the department was you had a lot of disparate kinds of activities going in different directions. And so as we were working more and more with our agency partners, we were hearing more and more from those agency partners about the need to have greater alignment in all of our activities so that we could get greater synergies across all of our activities. But also, trying to think about, how can we actually make it easier for this type of integration to happen so it doesn't feel like it's, custom, bespoke, one-off, activities based on which agency you're working with or which program with which agency you're working with. Couple that with the imperative from Secretary Becerra and Deputy Secretary Andrea Palm that that this department has to be more than the sum of its parts. That we've got tremendous agencies who are leading agencies around the world really in terms of the work that NIH and FDA and CDC and CMS and all of our agency partners do, but they can't be siloed. Right, we need to be working more and more together to be able to get the multiplicative effect of of what these agencies can do together, or more and more together. And so in 2002, Secretary Becerra put into place a policy that was called the Health IT Alignment Policy, which did two things. One, it required that all of our HHS agency partners base all of their programs, their funding, their policies on ONC-approved standards in the areas of clinical interoperability, both on the data side and formats and interoperability mechanisms. Really as a way to say we all ought to be working together on the same core foundation. And certainly, there are additional unique requirements for research or additional unique requirements for public health or, or for federally qualified health center reporting, whatever it is. But the point is that we should at least be starting from the same place, like the US CDI, like standardized Fire APIs, for example, and then build from there. So that was a policy that was put into place, and the Secretary's direction in that policy was also to ONC to establish technical assistance for all of our agency partners to help them incorporate these standards-based approaches into their mission activities. So that even more explicitly got us setting up account managers for each agency, working, really in roll up the sleeves fashion to be able to work with those agencies on how are they going to better accomplish their mission objectives. Fast forward, as we started doing more and more of that work, the department itself was looking more and more about technology in a much more strategic manner and thinking about the need for us to be thinking about innovation and strategic innovation and technology being a key part of that in healthcare. And also that we had more and more activities going on across the agencies, across the HHS agencies that were even above and beyond what we might traditionally call health IT that needed greater, sort of coordination and alignment. And so all of that led to, sort of a strategic imperative at the department to say, all right, we need to consolidate resources that are spread across different parts of, the HHS, and we need to be able to get more, sort of single point accountability leadership over some of these things, like data strategy, for example, like innovative technology strategy, for example, both with respect to what we do in the enterprise, as well as for mission-based activities. And again, I haven't even mentioned AI. All of this was work that was underway and they were thinking about. And then ChatGPT erupted and even made even more clear the need for us to have, sort of more explicit strategic, direction of the department. So all of those things came together to to establish the Assistant Secretary for Technology policy, really building on the chassis that ONC had already put in place, where you have that combination of policy people, technical expertise, regulatory affairs, and very externally facing agency, both within the department, working arm in arm and elbow to elbow with our agency partners, as well as working very closely with the market and a lot of visibility in the market as well.
Great, thank you. I know one of the challenges you've been working on has been interoperability. What kind of grade would you give the US on interoperability right now in healthcare data?
Well, I don't know. I mean, I think I would give I guess I'd give the US a B. And maybe that seems very generous, but I think it depends on, I think it depends on where you are coming from with respect to interoperability, and should it be, sort of adjusted for the complexity of the task, and recognizing the fact that we're never going to be satisfied, right? Interoperability is never going to be done. There's always going to be more and more needs, more and more demands for interoperability. I mean, think about your smartphone, right? The capabilities that were in the original iPhone that was released when, in 2008, 2009, yep, something like that. None of us would be satisfied with that now, right? We would look at that and say, that is the most primitive piece of junk that I've ever seen. But we were very happy with it then. We thought it was amazing. And so, I think that we just need to recognize that the ceiling keeps rising on this, as it should. But the reason I would give it perhaps a higher grade than some others might give it is in part of where we are and directionally how much progress we've made in a very short period of time over the last few years. We've spent a lot of time building that foundation of electronic health records, for example, and an important part of that is just to recognize that you can't have interoperability if people don't have electronic systems and the data isn't digital to begin with. And so, a part of this grade, when I hear people say, well, we've been working on interoperability for decades, it's like, well, yeah, except it's like saying that you've been building on phone systems for decades when most people didn't have a phone. The problem is that most people didn't have an electronic health record, so there was nothing to share. And so, one piece of this is to say that if you look at, sort of the adoption curve as it related to those public and private investments that were made in electronic health records, that really didn't reach 50%, which we can arbitrarily say that, all right, once you've got 50% adoption, maybe there's enough there that people find it, meaningful to think about sharing data. But that didn't reach 50% until 2014, 2015. And then you still had more and more and more to do with the tail. So I think that was one of the things that we just need to benchmark ourselves against, which is that, when do you start the clock, on those kinds of capabilities? The second is that if you just take an absolute measure of information shared right now, the care quality framework, which is a network of networks, private sector network of networks that brings together and connects up in some ways, Epic's Care Everywhere and the Commonwealth Health Alliance and eHealth Exchange and some others, they do something like 40 million transactions per day, 40 million clinical transactions per day. That's a lot. I mean, the Swift Global
That's a
Banking
lot.
Network is 41 million per day. And what grade would we give them? Would they get a B? Would they get an A? I don't know. So I think that, again, there's a lot of information that's flowing. I think some of the challenges and the reason that, that I would say we are not nearly close to being done again, and nor would we ever be, is that there are still a ton of gaps. That data isn't always usable. I mean, you hear a lot from providers that, great, you've now delivered it to my door, but it's in, 1,000-page, it's electronic, but 1,000-page CCDAs. And those aren't really usable to me. And so, we've got the next order set of challenges, which is how do we make that data more and more usable? How do we make it, sort of more and more something that people look forward to getting, not dismiss or, or shirk from, having to open up that other records tab and try to sift their way through that. So I think that's where we get to, the enablement of FHIR APIs and TEFCA. We've now got FHIR APIs that are available in all certified electronic health record systems as of December 31st, 2022. And we've got TEFCA, the Trusted Exchange Framework and Common Agreement, that's now live as well, with 7 QHINs supporting transactions, FHIR-enabled capabilities now live, a number of other things there. So I think when you look at all of that, it feels to me like we're in a really good place with a lot more to go, but a lot of things settling in for us to be able to, have a much more clearer line of sight to what's that future going to look like than we had even, 5 years ago.
So at NCQA, we're really excited about the SOP and TEFCA for HEDIS and so forth. What's your vision for why that SOP was put in place?
Yeah, I guess I would point to a couple things. One is from the beginning, as we were looking at TEFCA. So, when I came in, there was a version of TEFCA that was, kind of there. We took a really good hard look at it and did, a number of things to reset it. Because we had, concerns that it was, really not going to be, what we needed as the industry and what the private sector, was saying that they needed in order for, for us to get to the next level of interoperability. One of those areas, so we identified gaps, and those gaps were related in part to what we were seeing, and what I personally, before joining the federal government, I mean, I was in the private sector and was very much involved with a number of these health information exchange networks on the private side, and saw firsthand that they were great to getting us to that $41 million records exchange per day. Among providers for treatment purposes, right? And did a ton of work. And I think actually that they don't deserve, the people who did that, and there was a lot of people and a lot of hard work, don't get the credit they deserve for getting us to that point. But I also saw firsthand that was slowing way down in terms of the evolution of the next set of use cases that all of us wanted to be able to have. And as I observed that more closely, you started to see that those gaps were because they were too hard for the private sector to accomplish on its own. Public health being one of them. Very, very difficult for the private sector to figure out the federated jurisdictions that we have in public health and figure out how we can cut through all of that to be able to get at scale nationwide interoperability. Another one was the gaps, the digital divide. A large number of hospitals, 30% by some measures, that don't participate in nationwide networks that we need to be able to address. And again, the private sector has difficulty, with the tail. And the last one, and last one, not in terms of priority, but just to mention it, since directly addressing your question, is payer-provider interoperability. Seeing that in the vast majority of those networks, whether it's state and local HIEs, whether it's the nationwide, health information exchanges, that we weren't seeing payer-provider interoperability because of the competitive issues related to payers and providers exchanging information. And so we set that as one of our goals as well, as a gap that needed to be filled in the national interest and the public interest and the patient interest, and that we would try to use our federal government presence to perhaps help to adjudicate some of those issues to say, what can we agree on to give us a path forward to enable the payer-provider interoperability that all of us, need to be able to have. So that was one part of it for sure. The other part I would point to is related to some of the more recent issues that we've seen in the nationwide networks that have, been unfortunately eroding trust in national level health information exchange. And one of the things that we observed in that, and we had already been working toward this in TEFCA, but that even made it give a finer point to everything that we were doing in TEFCA, was to say that you need to be able to open up those other use cases beyond just treatment, to enable organizations who might be a little bit in a gray area of this treatment, is this healthcare operations. HIPAA in many ways is somewhat sort of gray in some of these areas by design, because the recognition that the model is very that the market is very complicated. But what that forced some organizations to do was try to justify everything as treatment, because they knew that that was the only way they were going to get a response. Not all, I mean, but some organizations were doing that. So the idea within TEFCA was to say you need to open up these other use cases to allow organizations to participate in the model that best that best meets exactly what they're doing, and that builds trust for everyone when people are able to sort of have those use cases that are most appropriate to what they're doing. So that was the other thing. We already had it in our sites. We're already working toward it, but all of the issues that we're seeing in nationwide interoperability over the last 6 months made it even more vital that we get that in place and get it approved by the TEFCA community.
And how do we, I mean, you touched on this around interoperability and data quality. How do we maintain data quality? How do you think we're going to get there and be able to get to a level of data quality that we're not going to be dealing with 1,000-page CCDA? We're going to be dealing with FHIR APIs. What's your expectation?
Well, I think we have to have business models that provide incentives, whether it's carrots or sticks, carrots and or sticks, that are aligned with what we might call higher quality data. I think from from my experience living on the other side of it, and with data analytics firms and interoperability for for a number of years, is that we all there's no standard definition of data quality, and data quality is always in the eye of the beholder. So if you're expecting an organization that's upstream of you to send you data that that meets your definition of quality, but there's no business arrangement or business alignment for the data that you're getting, there should be no expectation that they're going to deliver data according to your definition of quality, when data is a byproduct of a business process, right? They're generating data according to a data generation sort of process, which is really about what it is they're doing in the provider setting. For example, providers are documenting data for care. I mean, full stop, right? That's what they're doing. They're treating patients. And so when there's an expectation that somehow that data is going to magically become higher quality, or that providers are going to make data higher quality for other people to consume, well, unless there's a really strong business model about that, then I don't think that any of us should expect that, that the promulgation of more standards or the locking down of electronic health records anymore is going to solve that problem. So I think that, things like value-based care, for example, I think starts to drive a greater expectation about higher data quality. Why? Because people start to see interoperability as being a business need, and they start to see the ability to do quality measurement and utilization management and a whole bunch of other things as a core business need, not overhead. And then they start deeply incorporating, well, wait a minute, if I'm going to do that, I either need to be able to work with my partners to get higher quality data, or I need to be building capabilities on my end to curate that data and make it higher quality for my purposes without any expectation that, that the other people are going to do that. I'll just reflect on, when I first got into health information technology. So I've been in health IT now for, I guess, 24 years. So that's my time in healthcare. I was 24 years ago. And I started with working on a project with the Regenstrief Institute in Indianapolis, which is, legendary figures, right? Dr. Clem McDonald, Dr. Mark Overhage, Dr. Bill Tierney. I mean, these Mount Rushmore figures. And one of the things that I observed directly and learned from them was they started with, arguably the most successful health information exchange in the country now. I mean, they didn't start with that. We built that at the time, but what they've turned into, but what they had already built at the time, the Indianapolis Network for Patient Care, was groundbreaking. I mean, they were getting live data from the emergency departments all across the city, and aggregating that data and starting to research it and starting to make it available to providers at the point of care. Right? This is before the year 2000. This is like 1996. But one of the things that was a quick discovery for them was they originally started by trying to set requirements for data standards at all the sources, and basically trying to say that, oh no, the source systems have to deliver data according to this set of specifications. And I think Clem and the team quickly realized that wasn't going to work. That there was no way that they were going to get all those organizations to send data according to a standard that wasn't aligned with any of the business incentives that they had. And so they actually flipped the model. And the Regenstrief Institute had built a team of informaticians, physicians/engineers who were informaticians who built the capability to take that data, do code mapping, do curation so that it was standardized, but it was all on the data delivered and the curation of data delivered. Now, again, we can have a a back and forth about how do you generate the right incentives for people to send data that meets the downstream needs according to sort of business models. But just want to point out that that's been tried many, many, many times, and is why we've ended up with some of the ways that that we see the market behaving today.
So we have many payers listening to this chat, as well as public health professionals from the states. Can you speak about their different roles in interoperability and in data quality?
Yeah, I think it's huge. So one is that we're doing, for those who haven't seen our HTI2 draft rule. It's not for the timid. It's 1,000 pages. I take the point. And the comments closed on Friday, so you can certainly see all the comments that are on the website. But the comment period has officially closed. I'm sorry to report, although I'm happy to report, because now we can actually dig into those comments and move to the next step. But the HTI2 rule, one of the important things that it does, and I know it's difficult to see it in the specific line items of the 1,000 pages, but one really important strategic thing it does is it kind of recognizes that we've got these really big silos in interoperability: clinical care, administrative, payer transactions, and then public health, to name three. And then we've got research over here too. But let's just talk about payer. And obviously, I'm taking in the lumper splitter world, I'm on the extreme lumper side, for a moment here. But if you just think about those three big silos, those have been kind of separate in the ways we've kind of thought about it. And they have little tethers that connect them, but in very, very primitive and limited ways. And what we've explicitly started to entertain in the HTI2 rule is to say, we need to break down those silos. Everyone ought to be thinking about this as an ecosystem that is multidimensional and just has different aspects to it. So payer provider integration, public health provider integration, that needs to be a core construct as we think about FHIR APIs, basing things on US CDIs, having consistent conformance testing through voluntary certification, for example. All of those things ought to be things that we're looking at through the same lens. And and we've been delighted by the partnership that we've had with CMS, for example, as CMS has rolled out the CMS interoperability rules in January for payers to be able to do their part now in interoperability using modern approaches like FHIR APIs, and to enable providers to be able to access claims data through the Provider Access API, for example, through the Prior Auth API, for example, to be able to say that's the basic interoperability framework, and everyone needs to start, getting on board with the rest of the way that the rest of the internet economy works. And similarly, we've been equally delighted by our CDC and jurisdiction and partnership with public health jurisdictions as we start to move more and more toward sort of US CDI, FHIR-based exchange, and TEFCA-based exchange, where we've now got 50 plus state jurisdictions that are live on TEFCA doing electronic case reporting, and with the ability to do electronic case investigation through TEFCA and standardized approaches. So I think all of that gets us closer and closer to the ability to say that we can automate more and more of that information. We've proposed voluntary certification of payer systems, payer APIs. No, it's not. It's not a proposal to certify payers, and it is voluntary certification. And similarly, voluntary certification for public health systems that are purchased using federal dollars, with an eye towards saying to your point, Ed, how do you get higher quality data? Well, one of the things that we've heard over and over again from providers and electronic health developers is you've certified the pitchers but not the catchers. So you've certified the EHR systems and told the providers that they need to send things, transmit things in standards-based ways, but everyone on the other end, payers, public health jurisdictions, all have their own custom ways of doing things, and therefore we have to meet their custom ways of doing things. Well, why don't we figure out approach to get more conformance on the catcher side as well? And that'll do two things. One, it'll create greater synergies and better interoperability, better baseline interoperability. The other thing it'll do is it'll make it easier for those receiving systems to actually do the jobs that they want to be able to do. Public health jurisdictions that are basing what they're doing on the core construct of the US CDI will have much better luck being able to get the kind of quality data that they want to be able to get than doing the the custom kinds of approaches that exist far too often across the jurisdictions.
And you were saying that right now it's voluntary for the payers. Do you see, how do you see that?
And public health, and public health. Yep.
Okay. Very good.
Yeah, so just building on that point, it is voluntary certification. I will point out that ONC certification of electronic health records is voluntary as well. And so the way that works is that it's the certification is voluntary for the technology developers. So Epic and Oracle Health and Athena Health and eClinicalWorks. There is nothing that the Micky Tripathi as ONC ASTP can do to tell Epic you are required to get your system certified. But there are CMS payment programs, I think 18 of them, something like that, that do require the participants in those programs use certified technology systems. So similarly, you can imagine that in the future sometime, depending on how this unfolds, that maybe there are programmatic requirements through agencies that have direct programmatic programs that there are specific participants in, that you kind of tie that together in that way. But it is certainly voluntary certification, and there are no programmatic requirements on payers with respect to their API technology or public health jurisdictions with respect to their purchases of health IT systems using federal dollars. There's no requirements today that would require them to get voluntarily certified. But we like to step into this incrementally. So the idea would be to say, look, let's start with voluntary certification as the federal government, and hopefully that's beneficial to the industry. For organizations that actually want to operate, let's take payers and providers. If there's a genuine desire for payers and providers to interoperate, and now you've got the CMS interoperability rule saying there's a provider access API making claims data available. There's prior auth requirements on the payer side, and ONC is now proposing putting those into place on the HR side. If there is genuine desire to interoperate, I think we would all agree that conformance against some type of reference standard actually makes things easier, right? That all of us say, hey, we tested against this reference infrastructure. Could be, like voluntary certification that puts you through those paces. That'll make it easier for everyone to be able to do what we want to be able to do. If it turns out that the market actually isn't picking up on that and requires a little bit more, push, then maybe that's something that we need to address down the road. But my hope is always that the market just needs a little nudge and a little bit of help to help it move forward, and then we stop and see whether that works. And if not, we need to give it a little bit more of a nudge in the public interest.
And as we're nudging the market, how do we ensure that these policies are equitable and don't have unintended consequences? Yeah,
I mean, it's really hard. And in part, you face the challenges of, for example, and I don't have a good answer to that, right? But I think that the first step is being really cognizant of it, is to say, what are we doing? And obviously some unintended consequences you don't see. That's why they're unattended. But, but some you can have some line of sight to. So for example, as we think about, raising the bar with respect to certification of systems, I mean, we've seen this in the HR side, that many people point to, well, geez, your certification requirements keep getting higher and higher and higher. And now what you're doing is there are small developers who literally just don't have the resources to be able to meet that bar. even if they could from a technical perspective, they just don't have the resources to go through that kind of process or build that kind of software. And I think one of the challenges that we face, and it imposes costs, right? Let's not pretend that this stuff is for free, right? The minute you raise the bar with respect to certification requirements, software developers have to invest money in that. And ultimately, that means they have to charge a little bit more, and that means that the providers have to pay more, and that means that ultimately you and I pay more through healthcare. It's all obfuscated by the complexity of of the way payment works in healthcare. But certainly at the end of the day, it comes back to patients. In terms of higher costs of care, one of the contributors to higher costs of care. So we always have to be cognizant of that. I think that part of the challenge though is that what we don't want is to say that, well, we'll issue waivers for those who can't afford it, for example, or for whatever else, because the flip side of that is that what you're saying is that, oh, okay, so those who are traditionally underserved in the healthcare system are not going to get the benefits of advanced technologies.
Mm-hmm.
Is that what we're saying? Because we definitely do not believe that in the department. We believe very strongly that everyone should be able to get access to the best of what technology can offer. And certainly as a baseline. Obviously, there are always going to be organizations that are ahead of other organizations because they have more resources, but we want to make sure that the floor is always rising, and that there's always, sort of the benefits of what technology offers is, continue to be as broad-based as we possibly can. So some of those things are, how do we, through our programmatic activities, provide additional encouragement, additional resources for those organizations who don't have the benefit of those kinds of technical capabilities, to be able to lift them up to be able to participate in those kinds of things. So I would point to, for example, we have a program with SAMHSA to provide resources to behavioral health providers, for example, to help them adopt standardized technology, to help them have standardized data elements like USCDI Plus for behavioral health, we call it, for example, that allows them to more generally have the capabilities to be able to be integrated with the rest of the healthcare delivery system, even though they don't have certified electronic health records, but getting them on the path with those certified electronic health record systems. The other thing that I would just point to, and it was actually a point that didn't originate from me, but I thought it was such a fantastic point that I keep repeating it. I was at a meeting last week in Orlando with the home health and LTPAC technology vendors and providers, and a point that someone made that that we were talking about, and I myself was also lamenting that part of the sector did not get the benefits of meaningful use incentives and all of those incentive dollars. But someone else stood up and made the point, which again I think was just such a fantastic point, is that look, that is certainly true, but if you look at all of those dollars that flowed and the infrastructure that we're now putting in place and we're talking about sort of advancing on, things like the FHIR-based ecosystem, for example, things like TEFCA, for example, that all of those things came out of those dollars as well. And all of those things are actually lowering the sort of the bar on what you need to do to invest in from the bottom up to be able to connect to things that are standards based, right? You can have web-based technologies with FHIR APIs now that connect up to a certified electronic health record system that doesn't require that you have some huge IHE-based sort of technical framework and an EHR that is custom just to just to healthcare, for example, to be able to do that kind of interoperability. And TEFCA is doing everything we can to say, how do you lower that as much as you possibly can so that the cost of interoperability gets as low as possible, and the friction, for example, with a common agreement that applies across the country lowers that as well, so that it's more and more reachable. So I think we just need to, keep that in context as well, that those investments actually are making things easier and easier. And I think we'll start to see the benefits of that more and more over time.
So states are setting up exchange frameworks. Where do you see roadblocks and challenges from the state perspective? And what can we do about that?
Yeah, I mean, our country is federated. And we see that not just in healthcare, but in every single industrial sector. I mean, you could not go to a sector and a meeting in a sector where where there isn't a big panel on what to do about states that have different rules and different laws about air quality, about, standards related to, fire standards, whatever it is. Every single sector has this issue. Healthcare certainly, has this issue as well. And certainly with respect to, in general, that's always been an issue. It has, gotten more and more, kind of acute, I think, as you think about the differences in privacy policies, following, following the Dobbs decision. AI is yet another vector where you're starting to see differences in, in policies related to, AI. So I mean, we've always had this patchwork. Federal government certainly cannot supersede, nor, do we want to go and supersede, those policies. But, what we've been doing from an interoperability perspective is two things. One is to say, well, how do we just create something that is open to and inclusive of those kinds of activities for organizations that live in those states, and is available so that those organizations can participate in a common agreement, type of arrangement where everyone agrees to the same rules of the road. And in some cases, and I think we've seen this a little bit with public health jurisdictions, is that some of the differences that they have aren't really material. They're just have historical legacy kind of artifacts. But if the trade-off, and I've seen this in, personally when I've been on the private sector side, when you think about the trade-off of, oh, well, I can connect to this national network that has these kinds of standards, but my unique set of standards here or whatever it is are what is preventing me from doing that. Well, I actually don't care about those things nearly as much as I care about national scalability. So I'm willing to give up on some of those things. Now, yes, that is a local entity by local entity consideration, but I think that's a part of it, is to say, if we've got something that's real and robust, and something that you can connect to and point to, that starts to help people iron out some of those wrinkles and say, look, where do I just not care about that in the interest of national scalability and the interest of lower cost? So I think that's a part of it. We also do, and we're happy to have this conversation with any of you who are in jurisdictions and you'd like us to have this conversation, is we'll have conversations with our state government partners, for example, to just, kind of explain, look, here's where the federal government is with respect to considerations of interoperability, considerations of things like data segmentation, considerations of, AI, for example, and just to make sure that, there's a good understanding of what the federal, sort of direction is on this, and a way for us to understand where there might be, differences or gaps or alignment. And then, just have that as an open conversation. And that's been, something, and again, not with an eye toward superseding what anyone is doing, but really with an eye toward saying, are we just, both of us clear at the state level and the federal level of where we're headed and what our policy imperatives are here? And to the extent that there are things that we can align, great. If not, let's continue the conversation and, and see how we can best support each other.
So we've been talking about interoperability. Let's shift gears for a moment and talk about AI. And what's the ASTP's role in AI in healthcare?
Yeah, it's amazing. We got into 49 minutes without diving into AI. It's incredible. Yeah, our role is it started with the HTI-1 rule, for those who are familiar with that, where and this is prior to the creation of the Assistant Secretary for Technology Policy, the placement of the Office of the Chief AI Officer under ASTP, and then right now I'm the acting Chief AI Officer for the department. We're very much looking forward to getting our full-time Chief AI Officer, Chief Technology Officer, Chief Data Officer in place before the end of this calendar year. But our work in AI started with HTI-1, where really going back to the summer of 2021, we started working on what was then, people were, sort of talking about algorithmic bias as it relates to health equity and safety. And so the concerns were, we're already seeing, and this again predates when ChatGPT was made public. It was probably Da Vinci then, or this might have even been pre-Da Vinci, at OpenAI. But we're already starting to see that more and more algorithmic-based technologies were being made available either as a part of the native solution that was being offered by a certified electronic health record vendor, or integrated as a third-party system integrated into the system, that were already starting to exhibit issues related to sort of health equity issues and safety issues. And so we started doing work and saying, well, geez, we've already got in certification requirements related to clinical decision support systems. So, and again, recognizing that AI is it's part of a technology journey, right? It's not as if there was everything before and all of a sudden there's a huge cut point and then we have AI. Well, certainly generative AI is an inflection point and a new set of capabilities. But there's been a march toward more and more capabilities based on these kinds of analytic and data kinds of capabilities. And so we were already had in certification certain requirements related to clinical decision support and requirements for transparency about the CDS systems that are in the EHR product that we called source attributes. So as we were looking at algorithms and the growing sophistication of those algorithms, we started to say, well, we probably need to expand that understanding to really with an eye towards saying we should have greater transparency about these technologies that are in EHR systems. So that's what led to in HTI 1, we put into the requirement for greater transparency of AI-enabled technologies in certified electronic health record products. That's required to be made available to customers starting in January 1st, 2025. So just a few months away, we'll start to see those dashboards being made available. All of that got us on a path to being more and more involved at the department level as it relates to AI and as it relates to the department's ambitions to have, sort of a more all-encompassing HHS AI strategy. And then, of course, the executive order came out and there was a need for us to have either greater sort of accountability at the department level for that. So as a natural outgrowth of everything we were doing, that's how AI ended up coming, under the ASTP umbrella. And the role that we play now is really about helping the department, sort of consolidate and crystallize that department-wide strategy, recognizing that, what NIH does and what CDC does are very different in the healthcare value chain, right? That's, research, preclinical research and public health, very, very different kinds of mission activities. But we do have an HHS overarching perspective, over all of that. So that's one of the roles. And then the other is helping to coordinate our agency partners with their AI missions, their missions, how we can best enable AI-based technologies, and how we can help them work more and more together in areas where it makes sense. So again, going back to, sort of the direction from the secretary and the deputy secretary, making sure that the department in AI as well as in everything else is more than the sum of our parts.
At a recent event on a panel, you spoke about automation bias. Can you expand a little bit on that and describe the risks that this might play?
Yeah, so automation bias is a very well-known phenomenon with respect to software that drives automation of workflow. Where on the one hand, we have, and I think the tension that we have in healthcare is we have way too little that's automated in healthcare, right? I would argue that's a part of why our costs are so high, is that we have so much paper-based, or what was paper-based processes now is using electronic information, but still using the old paper workflows with electronic information. We haven't yet made that transition yet. And too little interoperability or interactivity of systems that allows systems to be built with respect to interacting with each other that allows us to automate things, back and forth. Prior auth is the greatest example. There are other kinds of, sort of requirements, business requirements, and other industrial sectors that they have automated that requires a little bit of adjudication back and forth, but they have automated that are similar in some ways in structure to prior auth. And they've done it in those industries, yet here we still have this unbelievably cumbersome, process. So we want to be able to have more and more automation, more and more interactivity of systems using rich AI, API-based capabilities, instantiated in Fire APIs. But the danger when you automate something is that there is a tendency for people either to do one of two things. One is to just stop paying attention because things are automated, and so they stop paying attention to it. And another, which is sort of even just a different an additional degree beyond that, is to pay attention to it, but assume that the machine is right when it delivers something that you yourself think that doesn't quite look right. And so that's the area of automation bias that I think that we need to be very cognizant of. And from our perspective, it's about saying, how do we make sure that our workforce is adequately trained to be AI users, sophisticated AI users? They don't need to be developers, right? They do not need to develop the next generation transformer model or be verbose in embeddings and model weights and all of that stuff. They absolutely don't need that. But what we do need is a workforce that is savvy with respect to what AI-based technologies are, how to identify where there are issues, and how to do it in a way that empowers them to be able to, do their mission activities in a much better way than they were able to today.
Great. And before we start with the Q&A, is there anything you'd like to discuss or mention before that we haven't covered yet?
No, I mean, it's really, we very much appreciate NCQA's interest and partnership in everything that we're doing. I think one of the things that we didn't talk specifically about is, we've approved the healthcare operations use case in TEFCA and a set of sub-use cases that allows us to build trust as we sort of get payers and providers to do more and more together. One of those sub-use cases was HEDIS-based reporting, or reporting or exchange of information to support HEDIS reporting. We think that's very important because that's important to the industry. So we're delighted to be able to get the TEFCA community to agree that that, as well as broader quality measure reporting, was a key use case that we wanted to be able to say that's a trust builder. People know that they have to do that. People want to be able to do that. Let's bake that in as a core healthcare operations use case from ground one. The next thing that we need to do is we are going to be launching and I know we keep saying this, but we're actually going to do it, is we're going to be launching our 10x10 feasibility implementation sprint for payers and providers who want to be able to roll up their sleeves and say, how are we going to get this done? Where the idea is that payers who now have to make available the provider access API according to the CMS interoperability rule, yes, that's 2 years down the road when they're required to do it. How about doing it now to make available claims data for providers who participate in TEFCA so that there's a little bit more of a sense of a level playing field? And then providers equally feel like they can make available the clinical information that payers want to be able to do, very valid functions on the payer side related to healthcare operations and quality measures and, wide variety of things, that both sides have the ability to do that increasingly with FHIR-based technologies. Let's get that started. You get the policy framework in place. You get people who are able to say, we can do this from a technical perspective, iron out a bunch of the wrinkles that we know will emerge as we go through that process, and get us to a place where we really can have payer-provider interoperability at scale.
Great. Eric, do we have any questions from the audience?
We did get a few great questions from the audience. We are coming up on time, so unfortunately, I don't think we'll have time for any, maybe one we can get to. Dr. Tripathi, we did have one question, since we have state and public health audience here, about ASTP's role in human and social services and integrating data on that behalf.
Yeah, that's a great question. So first I should say, thank you to everyone who's participating, and thank you, Eric and Ed, for the opportunity to be here. This is not your last chance. My email is micky.tripathi@hhs.gov. Please feel free to reach out to me, and we are happy. I'm either happy to answer your question directly, or I can get you to someone on my team who's much smarter than I am to really answer your question. So please take me up on that. We're always happy to do that. Related to the question, yes, another part of the reorganization and the expansion of ONC's role is explicitly putting us, sort of as a department lead for human services interoperability. So we've actually now got a team that's focused specifically on human services interoperability. We're building a strategy for that and working directly with the parts of the department like ACL, ACF, other parts of the department to say, how do we elevate that now to make sure that, we all recognize that this is the Department of Health and Human Services. And, for too long, the human services side of it, I think, hasn't really participated in this health IT, process that we've got. And we want to be able to elevate that and make sure that they're at the adult table, as it were, of interoperability and health information technology.
Well, that's great. Thank you so much for joining us. We look forward to hearing more about that at ASTP's annual conference, December 4th through 5th, I believe, in DC, and NCQA will be there, and excited to hear more about the great progress of the agency. We have a couple of quick announcements for those who can stick with us. We know we're right at time, but would love to update you all on some NCQA events coming up that we won't want you to miss. So next slide, please. We have 3 webinars for primarily our state colleagues coming up that we'd love for you all to join. The first is October 23rd This will be focused on the recent Medicaid managed care final rules and access rules, and how our long-term services and supports programs help align to those rules. On November 19th, we'll update you all on our health plan ratings and how states can use those ratings in their programs. And then finally, on December 2nd, we'll be doing an introductory discussion on our data aggregator validation program and how states have used their HIEs and other data aggregators within that program and within their state policy framework. And then if you go to the next slide, we also have our annual Health Innovation Summit. We will be in Nashville, October 31st through November 2nd. There's still space if you'd like to join us. We'd love to see you there. And then lastly, in a few short weeks, we will be at the National Association of Medicaid Directors here in DC, November 11th through the 13th. We'll have a booth, and we'd love to get in contact with you if you'll be there. So please reach out through our website here or our emails, and we hope to see you there. And finally, we just want to say thank you for all those who stuck with us an extra couple minutes. We look forward to continuing this dialogue and hope to see you at an event, an NCQA event soon. Thanks so much.